So as we've witnessed throughout the history of global health, the availability and affordability of health commodities, including vaccines, diagnostics, and treatments, have been crucial to scaling up services. The successful response to HIV, including the remarkable increase in access to prevention, testing, and treatment in low and middle income countries, was predicated on developing and applying innovative approaches to access for health commodities. And I want to list just a few of them because I don't know that everyone appreciates that some of these mechanisms were born from the HIV response. The widespread licensing by originator companies of antiretroviral drugs to generic suppliers, the advent of WHO's pre-qualification program to help ensure the quality of generic drugs, and the expansion of that PQ program into diagnostics, the creation of the medicines patent pool, who we'll hear from on this panel, to accelerate access to quality treatments through negotiation and management of licenses and pooling of intellectual property, the creation of a number of remarkable organizations, including UNITAID, PEPFAR, the Global Fund, all of which have supported pooled procurement to generate higher volumes and leading to reduced pricing. International trade agreements, including the WTO Doha Declaration and the TRIPS Agreement on public health. The creativity of countries themselves to overcome barriers to access, including distributor markups and prohibitive taxes and tariffs. And of course, the ingenuity and motivation that's come from affected communities as advocates for change. These approaches and more are now being utilized to shape the commodity market in the area of viral hepatitis programs toward elimination. Industry plays a crucial role, first and foremost in R&D to develop vaccines, diagnostics, and drugs that are safe, effective, and meet the needs of patients and providers, and then in marketing and distributing those commodities as effectively and efficiently as possible. So today we have a distinguished group of representatives for the 40-minute discussion who I'll ask a few questions. And just to list everyone off to start, we have Sophia Chao, lifestyle leader for infectious disease at Roche. Lifecycle, pardon me.
Lifestyle too,
I'd like to be a lifestyle leader.
I'd like to be a lifestyle leader. I'm going to bring that back to organization. I like the lifestyle.
Francesco Marinucci, Director, Global Market Access and Funding at Abbott. Tiffany Clarke, Director, Global Health Strategy at Hologic. Rachel O'Shea, Vice President for Global Market Access at Cepheid. Kedar Madhekar, Associate Vice President, Strategic Initiatives and Commercial Operations at Viatris. Rahul Lande, Vice President of Global Access at Hetero, and Charles Gore, Executive Director of the Medicines Patent Pool. So let's start with a couple of questions for the diagnostic representatives. So maybe, Francesco, just to break up the order a little bit. Diagnostic tests delivered at all levels of the health system, from point of care to the doctor's office to the hospital, have revolutionized the diagnosis of a number of diseases, including Hep C and Hep B. We're starting to see some innovations such as combined RDTs, for example, HIV and syphilis, and molecular multiplex systems to make it easier for patients to access multiple tests from a single sample. What do you see as the future for enabling easier diagnosis of multiple infections and indications, including viral hepatitis, for people wherever they seek health care, whether in the community or at different levels of the health system?
Thank you, David, for the question, and thank you for inviting Abbott on the discussion today. So I would like to start by emphasizing a point that you made, which is diagnostic solutions capable to diagnose multiple infections are available on the market, right? In different formats, in different packages. The point is that, while these solutions have the potential to improve access to diagnostics and making the diagnosis more comfortable for patients, these products are not yet where they are needed the most. That's, I think, our major challenge as an industry partner, how we can work together in this ecosystem to make sure our products are reaching the ones that need this product. So I think the innovation is really in looking at this challenge together and how we can use the resources within the private sector, just beyond the R&D, beyond the production, beyond the delivery of products, to make these products effectively reaching out those in need. Regarding viral hepatitis, I want to mention that Abbott has a very comprehensive portfolio spanning, again, different assays, platforms, and rapid tests. So let's say the enabler in terms of products, I think, has been addressed by Abbott. It is continuously addressed by Abbott by looking into R&D on a regular basis. What is challenging in terms of enablers is really to make, again, these products available in the right setting, to the right people at the right time. And again, beyond the portfolio, Abbott has shown experience and success and impact in supporting countries willing to eliminate viral hepatitis in terms of additional services, solutions, and support. You know, just to give an example, the training of healthcare workers in Egypt when Egypt launched the national hepatitis C screening campaign. But we also have, you know, resources, capacity, expertise to provide support for data management, data solutions, data capability that can be used for improving both patients management and also programs management. So I think these resources are somehow untapped by some of the stakeholders, and we would like to play an active role in this area. I want to conclude just to say that for us at Abbott, a key enabling factor is to keep having a continuous dialogue with all the stakeholders in the ecosystem, right? And this can ultimately result in more clarity on each party's perspective, but also to better understand what is the added value of the other organization, right? So you bring something, but the private sector can definitely bring something to the table. So that's why I'm here today. That's why we are representing Abbott, because we want to share our commitments and intention of being actively part of this journey together. Thank you.
Thank you. Rachel, maybe I can turn to you. What do you see as the forthcoming opportunities to enable point-of-care testing in settings considering more decentralized testing models for both Hep B and Hep C?
Thank you, Dave, for the question. And what instantly springs to mind, and I'm so pleased to be here, is that phrase, if you build it, they will come. And we've built them, and they have been available for a number of years. And I think this is what makes this forum so special, right? I really feel this coming together towards ending hepatitis by 2030. But very specifically, Dave, it's hard at this phase in the agenda to say something original, right? So many, and not repeat. So maybe you'll indulge me, because I think there are some key points that are worth repeating. And then maybe on behalf of Cepheid, I can add a little bit more color and granularity to those. So, you know, the role of decentralized point-of-care molecular testing has been, and the benefits of, have been well established. And we've had a number of speakers this morning speak about TB, HIV, for example. And, you know, earlier this year with the EXPEL study in Uganda, again, showing point-of-care molecular diagnostics in decentralized settings. And I mean, that's what COVID also taught us. You need solutions where people engage with care. And not only, and I think Meg spoke to this earlier this morning, not only are they cost effective, but they are cost saving. So I think really the kind of key opportunity is, number one, is to, you know, learn the lessons that have been shared, published, and the data and the evidence available from HIV and TB. And in these resource-constrained times, use that evidence not to repeat some of the inefficiencies of the past at some of those programs, but actually really move at pace towards implementation and scale. Very specifically, the expert fingerstick HCV test, you know, it's one of those tests that really extends the reach of the laboratory and really focuses on, and as we heard so eloquently this morning from the communities, the more marginalized and vulnerable people in our society. And that's what tests like these do. If I had to just hone in on a second, well, firstly making the point on the first, use the experience, leverage the data that's been garnered in the previous programs, learn from those. And I think that's where you'll get your efficiencies. That's where the opportunity lies. And then secondly, very specifically, a further opportunity is there are 20,000 gene expert systems across low to middle income countries today. That translates into close to 100,000 modules. Now, they're mostly in the TB and the HIV programs and virology. But the point being, and here's the real opportunity, is the capacity exists. The networks already exist today. So I would call on all of us as a community and honourable ministers that were here and spoke again so eloquently this morning, is really leverage those experiences that we have from those programs. Don't repeat the inefficiencies that we've also experienced in these programs. And then only truly then will we deliver on the mission to end hepatitis by 2030. Thank you, Dave.
Thank you. Sophia, maybe I can turn to you. We've heard a lot about the concept that we can respond to hepatitis without building new infrastructure. I think they'll turn it on magically. Molecular suppliers often have large footprints for testing across other diseases like HIV, TB, and COVID-19, as we've also heard. What opportunities can countries consider to ensure the optimal use of a multi-disease platform and to optimize integration across multiple vertical disease areas?
Thanks, Dave. So first of all, I'm just really humble to be here, to have this conversation, and to be able to contribute. And to sit here with all of us, I think we have one goal. So it's a privilege to be here. And I am not a lifestyle leader. I am a lifecycle leader. Unfortunately, not a lot of people know what a lifecycle leader is. So I am responsible for infectious diseases at Molecular Diagnostics within Roche. So literally from an ideation all the way to the product obsolescence. But we are so supported by colleagues like Global Access and Policy. So also show we're not just about the test. We're making sure that every step of the way, that whole continuum of care, there are people on the ground supporting that, because our goal is to get a test results to the patients that really need it. So in terms of exactly what you just said, the instruments, and many of our instruments are like this, right? So it's not unique to Roche, it's others as well. The instruments are designed to run various menu of tests, things in HIV, hepatitis, transplant, respiratory, COVID, that is one. So what I was thinking about this morning from all the talks that I heard is actually many governments probably already made the investment in instruments during COVID. So you actually already have a main tool in front of you. So it is about putting funds into hepatitis and be able to use that instrument to its maximum utilization possibility. But besides the test, what we're trying to do here at Roche is also going beyond the test. We're looking at how to collect samples efficiently. I think most of you know about the plasma separation card. That really changed the way samples are collected. Therefore, we're able to reach population that might be further away from urban cities and be able to collect the samples, send the card in, and be able to test it in centralized high volume settings. And we don't stop there. We're also looking at beyond the laboratories. So we have made a lot of investment in the African network, where we put people on the ground, be able to do training, education, also service, and basically providing that whole end-to-end solution, if you will. This morning there was talk on Egypt, so we were very much at the beginning collaborating with Egypt to make sure that they can really hit their target of elimination. And just last December, there was a program in Pakistan, because education is so important. So having all the specialists coming together, sharing experience from Egypt, from Asia-Pacific countries with Pakistan, that, hey, if you fund it, if you invest in it, it could work. So these are all things that we're facilitating and making sure that we get the right people in the room together, because it is a global crisis that we need to solve all together.
Hologic is relatively new in this space, so many of you might not recognize our name. We really entered the market just in the beginning of the transition from CD4 to viral load in HIV, and that is where I came from. And so it was with lessons learned in the early days of HIV management, as well as my company's policy, which I think was unique at the time. I think that's changed now, so we developed an all-inclusive, transparent price. And so let me explain what that means. For us, it was the Global Access Initiative. It was a single price per patient result that included placement of an instrument, the tests, the consumables that were needed to run that, service and support, and delivery to the place, whether that's central stores for a country or all the way to the lab. When we announced it in 2018, that was $12 per patient result, and that was for HIV, hepatitis C, hepatitis B, and HPV for cervical cancer screening. We've added SARS, dried blood spot, and the example goes on. I think what that really allows is for countries, when they're managing a patient population, they are going to say, we are going to treat 1 million patients, and how much is it going to cost us for diagnostics? And shortly after that, PEPFAR did their first consolidated tender and followed those same examples. One other piece that I think is important to note is we also included key performance indicators, which means we commit to keeping our instruments up 95% of the time. It can only break down so many times a year, on-time delivery, all the things that a country needs to efficiently execute a program. And these are reported not only to our funders, as well as our country partners. We collect them monthly and report them quarterly and have a discussion if we're falling down on things. So that is the concept of all-inclusive pricing. I think most of my partners up here now honor that as well. And so we're really excited to see an opportunity to leverage what has been done with HIV and the infrastructure and really capitalize on that and move towards hepatitis.
Thank you so much. Let's turn to treatment now, if we can. Kedar, the most widely used treatment for hepatitis B is tenofovir, given daily to patients at the same dose as a single drug as it is used in the treatment of HIV in combination with other antiretrovirals. For HIV, tenofovir is mostly manufactured in fixed-dose combination pills with dolutegravir and lamivudine. In Chai's first hepatitis B market report, we noted that many countries are paying higher prices for tenofovir as a single drug for hepatitis B than they are for the fixed-dose combination of 3 drugs used for HIV. Is there a reason that it might be more expensive to produce tenofovir singles, or are there other factors at play that you can talk about?
Sure. Thank you, Dave, for that question. And again, I'd like to thank you and the Hepatitis Fund for inviting us to be a part of this very important conference. I think and it's very important to look at, when we talk about tenofovir as a product, it's important to look at it from when the voluntary license was available way back in 2007 to where we are today. So I think we've seen a lot of improvement in cost, and that has happened through scale. And when we talk about tenofovir as a product in combination with other like lamivudine and dolutegravir, which is the current gold standard for treatment in emerging markets, I think the key difference between tenofovir as a plain product and a combination product is the scale. So obviously it costs more to produce a tenofovir because the batch sizes are smaller, and you obviously have to, when you talk about TLD as a product, I think you're manufacturing millions of packs every month. That sort of gives you the scale to realize the economies of scale. And whereas that is just not the case with tenofovir, I think there's hardly anything the demand is also very scattered, but hopefully with everybody coming together, if there's definitely scope for improvement in cost there, provided we are able to scale up the product. And another option again is to see if we can include TAF for hepatitis treatment. And I think everybody's looking to WHO for this in terms of when will TAF become a part of the treatment regimen for hepatitis. And that is, I think that at scale, I think there's a lot of potential in TAF to, because of the lower dosage, to be able to bring down the costs significantly. Thank you.
Thank you. Rahul, prices for the DAAs to cure hepatitis C have reduced substantially since their introduction, but there are still some low and middle income countries that are paying as high as $1,000 per patient course. Can you talk about some of the factors that influence these variabilities in pricing?
Thanks, Dave, for this question. And on behalf of my organization, Hetero Labs, I would like to thank the Hepatitis Fund, Chao, and the partners for inviting us for this important conference. Such a privilege to be part of this conference. Coming back to your question, Dave, there is a straightforward answer, but there is quite a background to it for the situation that we are in. So straightforward answer would be, there are price margin markups, including but not limited to the factors like the logistical costs, the distribution margins, the taxes and the duties in the countries, and so on and so on. But the background to it is we have been talking about since morning, and we all know about the statistics and the magnitude of the disease burden on the health system overall. We talk about millions of patients getting infected, millions of patients living with this infection, and 1 million dying every year. But if you look at the market from a manufacturer's perspective, the market is still very fragmented. There are a lot of agencies, countries, they have done some good work, but still it remains in silos. There hasn't been any coordinated intervention which has happened so far. So if some country comes up with some demand, to cater to that demand really needs a lot of efforts from manufacturer point of view. Also to get the treatment to the patient adds on a lot of costs. And that is why you see there is a lot of variabilities in terms of pricing which the patient has to pay. Most of the treatments are paid out of pocket by patients. So there is a huge chain of margins getting added when it reaches to the patient. So now if we draw parallels between HIV and Hep C, there are a lot of commonalities, but still Hep C as a program lags so much behind HIV. See, if I go back like 8-10 years, when generic manufacturers had signed licenses with MPP and originator companies, that time around the cost of treatment in developed countries for Hep C was about $85,000 to $90,000 per treatment. And that time, without any commercial commitments, generic manufacturers, I remember very vividly that they had announced a treatment cost about $1,000 for a treatment. And you see the gap, right? But even though such a groundbreaking announcement was made by generic companies, from programmatic point of view, there wasn't much intervention which was done. There wasn't any agency or a stakeholder who was focusing clearly on the treatment of Hep C and Hep C program. The governments had been talking about it, but they haven't been setting out a dedicated fund for the treatment of this disease. So I think there hasn't been any coordinated intervention happen. There hasn't been any catalytic funds which were made available for the treatment of this, which could really scale up the treatment, which could really give the leverage of economies of scale. And that is why there are no uniform prices available. So, thanks.
I'd like now to turn to Charles and get the medicines patent pool perspective on things. And Charles, I have a specific question for you, which is that we know the MPP has recently expanded its mandate in terms of diseases it covers, for example, including COVID-19. How do you see MPP evolving to support access to future technologies such as long-acting injectable or one-shot cures for hepatitis C, or some of the hepatitis B treatments that are now in development?
Thank you very much, Dave, and I'm delighted to be here. To talk about really long-acting first, we have a license from AbbVie for glecaprevir and pibrentasvir, which are good candidates for a long-acting version. Unfortunately, sofosbuvir, for chemical reasons, is not actually a particularly suitable candidate. And we also have a license from the University of Liverpool's spin-off company, Tandem Nano, for their long-acting device for this. And they've managed to co-formulate the two drugs so far, but there's still a way to go towards development. And we also need to align our licenses from AbbVie with our license from Tandem Nano, which covers all low and middle income countries. And our license from AbbVie is a great deal smaller than that. And so we're actually got a meeting with AbbVie to discuss this in about 6 weeks. It could be really transformational, I think, to have a one-shot cure where you've got a point-of-care test, point-of-care molecular test, and then a one-shot. But I'm sorry to say, don't hold your breath. There's still a lot of development for this. So, you know, we need to, I wouldn't want anyone to think, oh, you know, we've got such a lot of marginalized populations, we'll just leave them until that comes. No, 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 we've got very effective treatments now, we've got to make use of them. And then in hepatitis B, we're looking at this very closely. One of the things is that typically, when we get a license, the time between getting a license and a generic version being available on the market is around 3 years. And in COVID, that was shortened dramatically. And actually, Hetero came with a product within a year. That's also taking it through pre-qualification at WHO. And I think expectations have changed. And actually, when we announced the sublicenses for molnupiravir, the first of the COVID antivirals that we got a license for from Merck, I got a journalist ring me up who said, okay, so you're announcing these sublicenses, so how long before low and middle income countries will get them? And I said, well, you know, we're really hoping that it'll be an incredibly short time, it'll be a year. And he went, I'm sorry, a year? They're going to have to wait a year, like with the vaccines. And I really think that COVID has changed people's expectations. And we now need to be looking at within a year. So that means starting everything earlier. That means starting licensing earlier, starting the development earlier. And so we're watching it very closely now. We're having quite a lot of pushback from companies going, it's too early, it's too early. And we're trying to explain to them, no, it's not too early. And also in terms of our expansion, we're also looking quite a lot at the moment at hepatitis D. Let's not forget Delta. And seeing what the possibilities are there. There's sort of one drug that's really available is not fantastically useful in low and middle income countries because it's a daily injection. You basically can't really stop. There's a significant risk of flares if you do. Because it's injection, it's obviously relatively costly compared to a pill. And the fact that it's continuous is a bit of a problem. But what we can do in terms of licensing is great. And then with the help of the generic companies, we can produce affordable drugs. But the big problem, I think, or at least one of the big problems, is diagnostics. And when I say it's a problem, it's the use of them, the lack of use of them. And of course, COVID really focused attention on that because of the need to provide the medicines within 5 days. And if you look at the demand for the antivirals for COVID, it's nowhere in low and middle income countries because they're simply not testing. And that is also an issue in both hepatitis C and hepatitis B because unfortunately for the large majority of the time they're asymptomatic. And frankly, once they become symptomatic, that's probably when you're starting to have real problems. we have to do more in this. And so I'm hoping that in the kind of commitments bit here, the diagnostics companies are going to step up, because everybody needs to play a part of this. Price is one issue, but it's also the governments have got to invest. But we've got to show that things are affordable and easy to do, because we're in a world where, you know, a global fund for hepatitis is never going to happen. This has got to be the country stepping up to do it. And that's sort of the point of what this is all about. You know, can we do not just catalytic funding, but catalytic actions that will really promote change in governments? Thank you.
Thank you very much.